patients who are not ventilated or do not have severe disease. This is one of the guidelines that more recently was published. So they are suggesting with a weak recommendation for corticosteroids in patients with ARDS, severe disease or ARDS. And they're recommending against its use if patients are hospitalized but not severe and don't have ARDS. Both are weak recommendations because obviously there's been, until now, positive evidence in either direction. This guideline surviving sepsis campaign, you guys have seen this. It was published very early in the course of the pandemic, and it was based on it was same as before. It was based on findings in viral pneumonias and ARDS in general. And again, they're recommending against use of steroids in patients without ARDS. And they are suggesting, again, low quality in the evidence, but they're suggesting use of corticosteroids. The trial, I won't get into too much, but effectively parallel RCT was open label. It was an adaptive platform trial, so there are multiple other intervention arms, factorial design, and various interventions can sort of be added and taken away. But in this context, this publication was related to, or in this publication, they compared usual standard care versus dexamethasone 6 milligrams once daily. They included patients with clinically suspected or laboratory confirmed COVID-19, and basically clinician discretion as to who may not be appropriate due to their medical history. Nothing more detailed, not much more details beyond that. They did include pregnant and breastfeeding women, which is an advantage in this trial, as that population tends to be excluded from clinical trials, sometimes unnecessarily. Outcomes, as you'll see, were all-cause mortality at 28 days, and they had some secondary outcomes. They randomized overall about 6,500 patients. This was a 2-to-1 randomization, so for two people in the control group and one for every one in the intervention. And so you can see the numbers at the bottom there, 2,104 and 4,321 in the groups respectively. Their subgroups are important because there was a pre-planned subgroup analysis across patients who were mechanically ventilated, patients who were on oxygen but not mechanically ventilated, and patients who did not require oxygen. In general, and I'll go through this is the findings as you all know. So there was decreased mortality in the Dex group. There was a reduced length of hospital stay, and their composite outcome of rate of mechanical ventilation and death was also lower in the Dex group. So I'll start with the fact that obviously the trial has some issues. The main methodologic issues is that it's an adaptive platform, which is actually an advantage, but unfortunately, a priori sample size calculation is not usually conducted, nor necessarily appropriate in platform trials, in adaptive trials. The trial was stopped early based on interim analysis. So some would argue that may be limiting its the validity of the findings. But this is an adaptive design, so there were pre-specified rules for stopping. The study was the intervention was unblinded, so clinicians knew what their patients were getting. Whether or not that's a disadvantage is up for debate because their objective was the primary outcome at least was pretty objective, which was mortality. So one could argue that the blinding would not have influenced, the unblinded design would not have affected the outcome. There are some things that are less related to methodology and problems with sort of I would call stylistic problems with it, and part of the reason why some people are not necessarily happy with the way the authors approach things. So it's not peer reviewed as of yet. So it was published in as a preprint originally. As far as I know, it hasn't been peer reviewed yet. And the study results were initially released via press release by the authors through their institution, which is probably, they lose style points for that, because that's not the way science should be disseminated right off the bat without the baseline data. So those problems aside, the question is, should clinicians, as a clinician, would you, based on the findings of this study, prescribe Dex to your patients with COVID-19 in general? And obviously, not all research findings should or can be implemented. So what are some of the factors that you need to take into consideration, that we all probably take into consideration without necessarily always, having a structured approach like this? But the first issue is there biological plausibility? And if for the intervention in question. So I would argue that in this case, there is biological plausibility for the use of Dex in COVID-19 patients. We know that it's a mnemonic process, and there's extensive radiological opacities on CT and chest X-ray that suggest there's a pro-inflammatory cascade, as there would be with any other ARDS, any other cause of ARDS. On autopsy, there are findings also suggestive of a pro-inflammatory process, and we know that inflammatory markers like CRP and interleukins and ferritin are elevated in patients. So with corticosteroids, corticosteroids having an anti-inflammatory effect in part, one could argue that there's biological plausibility for administering Dex or corticosteroids in general in this patient population. So the second question that we generally ask is, would my patient be included in the clinical trial that I'm reading? And I would say that the patient population is fairly reminiscent of the types of patients that we treat in the ICU, in terms of not all of them are ICU patients in this study, but just looking at the invasive mechanically ventilated group, age distribution, gender, more males. I think that's kind of what we've seen to some extent, and a wide range of comorbidities as well. So the reason to ask that question is whether or not the findings would be relevant to your patient, and I would argue, on the whole, exceptions aside, it would be relevant. The third factor would be, what were the study findings? And I summarized it earlier, but looking at the forest plot, you can see that in patients who were not requiring oxygen, there was no benefit and potentially a trend towards worse outcomes with dexamethasone, but certainly not statistically significant. Among patients who required oxygen but were not ventilated, there was somewhat of a significant benefit, and in patients who were invasively ventilated, there was a significant benefit as well. If you calculate the number needed to treat for each of these groups, the number needed to treat for all comers would be 33. So you'd need to treat 33 patients to have one positive outcome. And this is for mortality, which is, that's a pretty good number. Number needed to harm for the no oxygen group, just there was a trend, it was about 26. And the number needed to treat for oxygen only patients was 29. And the number needed to treat, at least based on this data, among invasively ventilated patients was actually 9, which is pretty impressive. They did some subgroup analyses, so I'll skip those. They also found a similar trend or similar findings in length of hospital stay, as well as a composite outcome including both invasive mechanical ventilation or death among a subgroup that did not initially require ventilation. So very similar findings here as well. And the rest is pretty straightforward. Are the findings valid? One of the factors that you want to consider is the quality of the study, so the risk of bias. So in randomization, this is based on a network meta-analysis group that is evaluating all these studies in duplicate and assigning study qualities and summarizing them. But they determined that randomization had a low risk of bias. The study had a probably high risk of bias in terms of deviations from the study protocol. I think that might have been more related to the unblinded nature, though. There was a low amount of missing outcome data. I think 5% were still in hospital without an outcome determined yet. And that shouldn't be missing outcome data. That I think that is selective. I can't remember what that one was supposed to be, but outcome measurement was the primary outcome was pretty objective. So outcome measurement had a low risk of bias, and selective outcome reporting was low risk of bias. It was as per their original protocol. And then you have to think about whether or not your particular patient has any comorbidities or contraindications that would make the study intervention a problem for them, or less effective for them, or more associated with adverse effects. And if you think about patients with diabetes and baseline hyperglycemia, that may be one effect, but I would argue that that is relative to the fact that the study primary outcome was mortality. I think that's a sort of a complication that one might be willing to accept. And finally, what are the risks of not administering this therapy to the patient? Well, we know that the case fatality rate for hospitalized patients based on international data is quite high, so about 30 to over 50%. And again, given the clinical importance of this particular outcome, that's a big number. In the UK, where they did the study, the case fatality rate for that population was 26%, again, quite high. And the rate of patients requiring mechanical ventilation after admission to hospital was quite high. That's also UK data. So we know that continuing standard of care, this is what we get internationally. And so I'll leave it at that. And then the final factor, and I think very important factor, is what would your patient want, or what does your patient want, which is sometimes more relevant in other types of interventions than in critical care, but it's always important to consider, factors like patient values and preferences. And that's all I got.
They want to live, Kimia. They want to live.
Are you sure about that? Well, if they don't, then you're having goals of care discussion, John.
I'm just gonna bring in Ian here. He's my muscle. Hold on.
You need it back. Is your presentation?
Yeah, no, I'm gonna just try to make it so that he can hear while I talk. Okay, so I do have a few talking points. Thanks for that awesome summary. So in terms of looking at the study, I'll start off with the low-hanging fruit. So obviously it's not a blinded study, which again, is understandable given the fact that this was done during a pandemic, and it's really hard to actually do a placebo in such short time. But it does create a source of bias that we have to acknowledge. One of the things that I wasn't a huge fan of was the fact that they excluded, patients were excluded based on the opinion of the treating physician. So if they had a medical condition that put the patient in significant risk, they were excluded from the study. It's just, to me, it's very unclear how this would have been adjudicated. And it just also implies that patients may not have necessarily been consecutive enrolled in the trial, or screened for that matter. And so that's something that I had a bit of an issue with in terms of the study. And I know you mentioned that there's the trial, like the actual patient demographics, make it seem like these are patients that we treat, and some of the demographics are. But the fact of the matter is that there's a lack of granular data, and that really makes me uncomfortable. What I'm not sure about is the fact that patients who are in shock, sorry, give me 1 second here. Some patients who are often on mechanical ventilation, which is the subgroup effect that they reported the biggest effect size in, are typically patients that we've seen show up with like cardiovascular collapse and shock. And it's really unclear to me if the usual care group actually got steroids. So they didn't report that. I don't know how many patients got hydrocortisone in the usual care group, and I'm not sure if the effect size we're seeing from dexamethasone may be due to the fact that it's being given to patients who have quite severe shock. From a methods point of view, I totally agree that sometimes a priori sample sizes are not done for these adaptive platform trials. However, they should have stopping rules. And the other thing that I couldn't find in their protocol, their supplementary analysis, or even the registration is how interim analyses were done. They're done pretty frequently. I think they were done like every 2 weeks or so. And I don't know what the stopping rules are, and I don't know how they adjusted for the type 1 error from that aspect. I think even like this, the wording specifically, it says that there was an independent DMC that reviewed the data in unblinded fashion, and then they provided a recommendation to the steering committee as long as they felt the mortality evidence was enough. And so obviously, without understanding what the stopping rules are and how the adjustments were made to the alpha spending, that kind of makes me a bit uncomfortable. And then I think you kind of mentioned subgroup, Kimia, and yeah, I agree that there's some biological plausibility, but there were guidelines I think published back in like early 90s that actually looked at like 3 major domains when we actually look at the credibility of a subgroup, which is important here because they really reported a large effect size for mechanical ventilation, and they generally come down to design, analysis, and context. And while biological plausibility touches upon context, the analysis and the design parts, there are some things that undermine credibility. So the hypothesis was not specified a priori, although they did say they were going to do an analysis a priori. The direction of the effect was also not specified a priori, and they actually tested a fair number of hypotheses beforehand. So that kind of takes away, it just kind of undermines a bit of the credibility of the subgroup effect that we see. It's hard. It's also something that it's tough because COVID is obviously new. There's not a lot of literature, and the evidence body is in its infancy. But we don't really see this consistent benefit. There's no other studies to say that dexamethasone has improved outcomes for us to compare it to. So this is just kind of a standalone here. The other thing is important to note, especially from the subgroup point of view, is that I think the randomization was done as a simple randomization schedule. So although the groups look balanced, the numbers were big, it's really actually impossible to know whether or not the subgroups were balanced by randomization because they didn't do stratified randomization. So that's another consideration as well, and there may be some confounders there. And then finally, and you've touched upon this as well, Kimia, the decision to influence practice is not just about the number needed to treat, but we also look at harm, scalability, and costs. And right now, the evidence body is in strong support of giving dexamethasone for COVID-19. We know that for severe pneumonia or pneumonia and ARDS, the evidence for steroids is mixed as it stands right now. And then the other thing that I don't think this trial addresses is how do we approach the different phenotypes of COVID-19? They're saying this is more immunomodulatory than the patients that are non-low compliance. Do we not give them dexamethasone? How do we treat them? So there are some questions that that have not yet been answered, and I have got a lot of those.
Okay, excellent. Well, thank you both of you for sharing that information. Does anybody from the audience have any questions we can pipe through to our presenters, or maybe I can ask a few?
Do we get a rebuttal?
Yeah, go ahead.
So I think just a couple of things I wanted to say in response to John's comments. The sort of low quality aspect of parts of the study, I totally acknowledge. So unblinded. However, the outcome that we're looking at, the primary outcome, is challenging to influence, even though it's an unblinded. If it was something different, even duration of mechanical ventilation, one could argue that could be influenced by the clinician's awareness. And you mentioned the ICU subpopulation in shock, and that's a good point. So in shock, use of steroids is also recommended, but probably not Dex. So that would be, it has very little, if any, mineralocorticoid activity. So I don't know if the sort of having shock or not would have affected their outcomes. They may report those numbers in their actual publication. How many people in the control arm got steroids? You mentioned they reported a crossover rate of 7%, which is not significantly high, but so 7%, but they actually used intention to treat analysis. So I mean, which is appropriate. So I think that would be, I would not be as concerned about that. The other thing is that even if they did report per protocol analysis, even if you just look at that, having a high crossover rate, which they don't, would actually increase your chance of a type 2 error, which we did not. So we're not, in this case, accepting the null hypothesis. So it would actually make it less likely to be a positive study. And so despite whether or not, you consider 7% a high crossover rate, you still had a significant effect on mortality. I agree, their interim analysis was not the most well described. They did mention that they had a threshold where if they reached a sample size of 2,000, the data monitoring committee would reevaluate and see what the probability, if the probability of reaching a different outcome with more recruitment would change. But it wasn't as well described as some of the other platform trials or some of the other trials where sample size, a priori sample size calculation is not reported. They usually report very detailed interim analyses. Even their protocol doesn't present that. I think there are other evidence. You mentioned sort of a lone study. I think there are other evidence that were reviewed by the guidelines, but again, you're right that it's very mixed. And yeah, and good point on the subgroup randomization. I don't know if they, it didn't seem to be sort of an issue just by visual inspection of the table, but they did not randomize, and yet it was their primary. It was an a priori analysis to look at those subgroups, but they didn't randomize based on those.
Yeah, no, I think if like hydrocortisone shock, or maybe they didn't get any steroids at all. I mean, I'd hope refractory shock. So that's kind of why I was saying whether or not dexamethasone acted as a steroid for the group. Yeah, and then to answer Karen's question, yeah, randomization was concealed and it was centralized. Yeah.
I think Claudio has a question as well. We can go to him and then I can pipe in.
Yeah, thanks, Kim. Yeah, John, for that overview and raising some great points. It's amazing how people continue to come up with new spins on things. I totally agree. The way it was released was very unconventional. An adaptive study design is very new, and I'm kind of like, I think it's an interesting idea, but they have to publish. You'd think they'd have to publish the details even more thoroughly, because I think people need to be convinced that it's. I mean, just because they're doing a new adaptive study design doesn't necessarily mean they're doing it well. Just like any clinical research, so it'd be good to see more details. Around your points, yeah, I think that was a good point, John, that maybe they had unrecognized shock and the mortality benefit might have been due to that if we didn't know how that was being managed. My question, though, I guess, is how does this fit in context with other studies such as the DEXA ARDS study, and how did they choose that dose? Because that's actually quite a low dose. And when you put in equivalent of hydrocortisone, it's only 150. So that's not even the dose that we would use for steroid replacement in refractory septic shock. So yeah, I found that kind of puzzling as to, and wonder if you have any ideas. So into the mechanism, but if the dose wasn't effective, that was a big absolute dose reduction, 10% absolute, which is bigger than we actually expect when using steroids for septic shock. So that would be, I guess, the counterpoint to what John mentioned around that. But anyways, those are my comments, and I guess the question about the dosing and any other insights you have into the methods and how well they, did they, as far as did they conduct an adaptive study design well, or did they just think, oh, this is easy to do, let's just go with it?
Who wants to field that question? Can anybody comment on whether or not they felt like the adaptive trials design was done well? I actually was going to ask that question just as a Luddite non-clinical epidemiologist. What exactly is involved in an adaptive platform trial?
Can you guys hear me?
Yeah, that's perfect.
Yeah, I mean, so adaptive designs are there's potentially hundreds of different designs that you can have that fall under the adaptive design umbrella. I think it was actually pretty well done. they like the hallmark of adaptive designs is it's in the name. It's that they have to adapt to the situation. And it was designed with the intention of evaluating interventions that were present in the here and now that are already approved for other indications and whether or not they can be applied quickly to COVID. And so the randomization schedule was allowed for usual care, but also allowed for several other drugs. And they did the updates and interim analyses periodically to like drop out arms or to include arms based on efficacy. I think overall it was well done. I would have appreciated more data on, again, like the interim analyses and how that was done, how they adjusted for the type 1 error and the multiple analyses. But I wonder if that may be in the main publication when it comes out. But I didn't see it on their statistical analysis plan. I didn't see it in their protocol. It wasn't on clinicaltrials.gov as well, and it wasn't in the manuscript that we have.
They do have a statistical analysis plan. I think, John, were you referring to the one on the website?
Yeah, I went to the one on the website. So like they kind of mention in the, I think it was the supplementary appendix, they were like, yeah, we have more details on the website. And I went there and I saw like kind of what they were doing, but it wasn't like, oh, like we did this, these are our stopping rules, et cetera, et cetera. And oftentimes these are the stopping rules for these adaptive designs are pretty complicated. So I don't know if they usually don't report them, but I just didn't see like it was there. All they said was they would adjudicate whether or not the effect size was big enough to continue and move on. And usually for these, they actually do have like boundaries, which they follow. Like, you know, if the, like, for example, it may be like an effect size they report, or it may be that like, this is the effect size we have, but the power that we based on the effect is like so low that we have to recruit like that, like, you know, a huge number of patients, then that arm may sometimes get dropped. So you have these guidelines to go off of, but they didn't report any of them.
So to add to that about it's a platform trial, so that they can add in arms. So like when they started this back in March, there was not much to go on in terms of just like even observational data. So they started off like they had hydroxychloroquine, which I think they dropped after, you know, whatever stopping rules they had for that. Steroids were part of it. Azithro is ongoing. They've got a couple of antivirals ongoing. And then as new evidence emerges from other literature and from within their own study, the benefit of a platform trial like this is that they can just add arms, as opposed to being like, okay, now let's do an RCT, Azithro versus, you know, standard of care, hydroxychloroquine versus standard care. You're doing multiple studies and you're exposing many more patients to standard of care, which may or may not be a good thing for those patients. But it certainly, you're having multiple studies with multiple different control groups. In this kind of a platform trial, you know, one control group, in this case 2-to-1 ratio, but one control group, multiple interventions being compared. Yeah, so they've got a bunch of things that are underway. I think this was their first one that they're trying to publish. I agree, though, they did not have as much detail in their pre-planned sort of interim analyses and stopping rules. Like they don't even mention stopping rules in their protocol, in their statistical analysis protocol, which is, I thought it was unusual, but.
I mean, this is still an impressive feat, right? I think it was like 100 days from when they created a protocol to like.
I know. It's probably a ton of work. Like, yeah, we'd still be waiting for Lawson here.
It's funny, but it's not.
Can somebody maybe comment on maybe Kimia's point in terms of applicability here with a patient population with invasive mechanical ventilation and a viral infection, to not have data on things like pronate, fluid balance, neuromuscular blockade, ECMO, like the lack of co-interventions, especially in an unblinded trial, should that give everybody, you know, cause for concern, or does the hardness of the outcome sort of negate that lack of co-intervention data?
So, I mean, this is the price you pay, right? Like you don't get a, you know, several thousand patient trial out in like essentially less than 100 days without compromising something. And I think one of the things they compromise is the granularity of the data. They leverage a lot of databases in terms of getting that data. So that's why you give up like the things like, you know, how many patients were prone, how many patients were on neuromuscular blockade, but that's kind of the price. And that's, to me, like, that's what gives me a little bit of pause for the study is I would have liked to see a little bit more and understand more of the population and how they were treated. But with that said, it is a pragmatic trial and their corners were cut. But this is what you get when you do a massive trial during a pandemic.
Like the other big question is this just the first sort of this similar to other therapies in critical care where the first trial comes out with a too good to be true, massive effect size? It's one trial. There are limitations like not knowing whether or not patients had low tidal volume ventilation. And then subsequent trials are going to come out in the next 6 months or a year, either trimming back the effect size, because this is probably one of the most massive effect sizes of any therapies in ARDS, or in, potentially patients with ARDS we don't even know if they had ARDS. Do you think it's going to be clawed back soon, and is this just hopeful optimism, or do you think that there's this is going to be the exception?
I don't know what others think. I think that it's certainly possible. We're very pessimistic in critical care. Like, as you said, things start off really well, and you get excited about a mortality effect or some other effect with an intervention, but then very soon after that, a few years after that, it all dies down, and so we tend to be very pessimistic. So I don't know. I tend to think that maybe with more evidence that effect size is going to be far less attractive than this study found. But I don't think necessarily we're going to sort of steer in the opposite direction, that it's harmful. So I think with the sort of outline that I was suggesting, we could follow, which is sort of looking at, applicability to our individual patients one at a time. It seems at this point, in the absence of newer data, I think it's still worthwhile strongly considering it.
Yeah, and to build on that, I think there's actually a recent meta-analysis that was done that showed a trend towards benefit with steroids. I think it was a COVID-19 or viral pneumonia, but I mean, I think this, like the story this trial is portraying actually fits with the evidence, I think, or like the direction of the effect of dexamethasone. What was I going to say? Yeah, I think I'll just leave it at that.
The other question I had was with respect to biological plausibility, and maybe this is related to your comment about phenotypes, John, but does the fact that there was a sort of the opposite direction, or the treatment effect direction was opposite in patients who were not on oxygen compared to patients who were on oxygen invasively ventilated? I know it wasn't statistically significant, but it was sort of on the other side of the forest plot. Does that argue against biological plausibility? Like, wouldn't you think that all of them would be on the same side favoring dexamethasone?
That's a great question, Paul. I'm not sure. It's funny that I actually just recently learned this, but apparently in the UK, like a lot of their patients get put on oxygen therapy, even though their sats are like above like 92, 93, you get put on oxygen to bump up your sats. So I don't know if that's playing a factor in making the direction of the effect go the other way. So yeah. Actually, one other point I forgot to mention, there is a meta-epi study that was published, I forget when it was, but it basically said that studies that are usually stopped early for benefit often, and then are published, actually tend to overestimate the effect size of an intervention. So it may very well, and just maybe just be due to a bias. So it may very well be that the effect of dexamethasone may be a lot better than what it may truly be. So there may be an overestimation that may get a bit of a clawback with subsequent studies.
I feel like that's just correlating something with itself, because you're more likely to stop the study early if you have a larger effect size. Like, if this effect size is smaller, then you may need thousands and thousands, whereas you might stop.
It's kind of like a self-fulfilling prophecy, but yeah.
Paul, I was going to say something to your point about, so biological plausibility, it's tough to know, but could we argue with the phenotypes that are being discussed right now? Could you argue that patients who are requiring oxygen or have more severe illness in some shape or form have a hyper-reactive inflammatory response relative to those who are just kind of like, managing okay, they don't need oxygen, they may not have as much of a inflammatory response, so that steroids would not only not be beneficial, but then potentially harmful due to their other effects. Hard to say at this point.
Okay, great. Any other questions from the peanut gallery?
Questions?
Okay.
Sorry,
go ahead, Karen.
one question. The full paper, where did you find it?
It's it's a preprint right now. And actually that's one of the things that, like, some of the stuff that we're wondering, I bet you once it gets peer reviewed, they're going to ask, like, how, shock, and, when did you do the interim analysis, and what did you find, and things like that. So I think that'll get sorted out. But Karen, I can send it to you. It's a preprint. So I think if you just, I Googled the name, and it's on that Medrix thing that everybody's publishing in.
We skip peer review process.
It's just it's one of those things which I understand people doing this for clinical trials like this, but everybody's publishing their, like, case reports and observational data that have nothing to do with treatments and epidemiological studies. Like, they're publishing everything as preprints, which is kind of like, what is the urgency in me to, in anybody, any clinician or any other researchers knowing the results of, your minor, not minor, important yet not life-altering thing, finding, whereas you could take the time to actually let the peer review process go forward. With recovery and with studies like this, I understand, because there may be clinicians that choose to change their practice based on this, which would affect people's lives. But just my 2 cents on that.
Can someone explain to me, I'm the grumpy old man here, why we're like, what is going on? You can't publish data before it's peer reviewed and published. Like, what? My world has just been turned upside down. Like, please explain.
Like, science has been turned upside down.
This is the new thing now. This is what we do. Yeah.
I honestly think it originally started with the good intention of, okay, by the time we go through the peer review process, like, it's beginning of the pandemic, it's like February, March, and there's no data. So whatever you got, share it, because the rest of us need to know. And then it kind of got out of control. Now there's surveys on there, there's qualitative interviews on there. There's like there is no urgency. Like, those findings are very important. You guys know I know that, but it's just if there's no urgency, if there's no patient outcome effects of your trial immediately, then I don't know that you need to just sidestep scientific processes to publish. So I totally agree with Ian.
Well, I mean, this was really
peer review would be but the problem is that they want to have their cake and eat it too, right? So they want to get the preprint out, the mass media effect, get all the kudos, and then they still want the New England Journal or Lancet or somebody to publish this paper. In my mind, the way things should be is that everything should just, like, they should just, it's all about open access to everything. So just publish it and let the peer reviewers go at it on Twitter. I mean, the best, like, the peer, when you get 4 or 5 peer reviewers, we still see, like, how much stuff's gone through peer review, and we still wonder, like, how did that ever get through? So I don't have an objection necessarily with changing this whole peer review process to something more global like that, but in this case, they put it out by media release and expected people to change their practice without showing all the data, and it seems, I don't know, I got so fed up with it, I didn't even pull up the preprint when it became available. So again, appreciate you guys looking through it, but from the sounds of it, they still have not fully disclosed all the data that's available.
The preprint is the manuscript. They probably, like, I think, if I'm understanding correctly, the preprint is what you're going to submit to New England or wherever you're going to submit to.
Yeah.
And so the advantage of the peer review would be, like, if somebody like John was reviewing or had the similar mindset, they'd be like, please report the other important variables that you're just not reporting. Report your interim analysis, report frequency of shock, ECMO, all that stuff, which I know they collected because they said it's one of their outcomes in their protocol, but this paper is really skimpy, just doesn't report everything that they have.
Yeah.
But the data is there. Like, they have they have the sort of values, and whatever is normally in New England is there.
Yeah. My point is that we don't necessarily have all peer reviewers as thorough and diligent as John and you might be. And like I said, we still are astounded sometimes at what we've seen in the supposedly high quality journals. So, like, we get more of our better critiques of the evidence by hearing what the EM crit blogger has to say, right? Then it got through peer review, and yet, like, things get through peer review, and then all the Twitter and bloggers get on it, and you find like all sorts of, you know, other issues and spins on it. So so if the intent is to get new evidence out there so we can shorten the time from discovery to implementation of effective treatments, then this is the route we should go. But it's got to be one or the other. I don't think, you know, I don't see the because now they're holding back on certain stuff because, oh, you know, here's a little sampler, but you have to wait for everything until it goes through the full peer review process. And that's where I start to have issues with it. My editorial.
Do you Claudia or others, like, do you guys think that journals are more likely or less likely to publish, you know, the higher tier journals, are they more likely or less likely to publish something that's already in preprint, or does it affect their decision?
I suspect something like this, so I'll still get lots of views once it gets officially published somewhere. So yeah, I'm pretty sure that they're submitting it to one of the high tier journals and it'll probably be picked up because they're all like, and it's going to be because, well, if I pass on it, my competitor's going to, there's a risk my competitor's going to take it. And I don't want to, like, it'll have nothing to do with this. It's just they're not going to want their competitor to scoop them on something that they passed up on,
which is going to be cited quite a bit because it's the first and only that we have so far. But I wonder if for less prominent or less attention grabbing articles, I wonder if that like if you're submitting to like New England or Lancet, like historically, to Ian's point, historically it's been that you can't publish your results before you submit, and you have to sign something saying I have not published my results. But here you are, like, publishing the exact manuscript that you're submitting online. Just kind of it's like everything's upside down nowadays.
Well, Kimmy, the other message that we've been getting is I'm interested in the experiences of others, whether, you know, people on the call right now have been submitting non-COVID publications in the last 2 months. But I got this one response that said, we're really prioritizing COVID research right now. Sorry. And it didn't say, like, you know, send it back and when COVID settles, like, we'll be interested or not. It just, that was it. And it was like, so I don't think the paper I'm trying to publish is a bad paper. But I'm having a lot of trouble because it's not COVID. People just don't seem very interested right now. I don't know what others, if others have experienced something similar, or maybe I just need to be more realistic about my paper.
I think some journals more than others right now are really just like going crazy with the COVID literature and ignoring everything else. But I've noticed, like, ICM, like, these are high tier ones, but like ICM, for instance, they send these emails, and like out of every 5 emails that they've sent, one of them has something about COVID. They're publishing on their usual stuff. So, like, I think it varies.
And we're submitting to general medical journals. So we have another paper, like a trauma paper, going to a trauma journal. So hopefully it's not an issue there, but
I would love for them to be like, sorry, like, we're only accepting.
We want trauma COVID.
Yeah. COVID.
Oh, man.
Any other questions about the recovery trial or dexamethasone, or any other thoughts before we close? No. Okay.
Are we going to vote?
Dexamethasone? Yeah.
Oh yeah, you should do a poll, Paul. Can you do the poll?
You do a poll?
Let me. Why don't people just write in? Let me give me. I'll try 1 second.
There should be a poll thing at the bottom, but we don't have it because you're host.
Yeah, I do. Yeah.
Oh, this is great. I'm excited.
I'll put the names beside it.
Can I redo my spiel just to?
You can give one closing line. How about that? Yeah.
John, do you want to go ahead?
Well, after you. I would entrust the care of my patient to dexamethasone.
Sorry?
I would entrust the care of my patient to dexamethasone.
And I'd say they have almost a 50% mortality rate. So what do you got to lose? This is the best we got, though.
All right. There we go.
Our names too.
Voting for Kimmy.
John undercut himself a little bit there.
Did you vote yes?
I voted yes.
You can't say that.
Work on John's debating skills.
He convinced himself of the opposite.
Well, as the results are coming up to 30 seconds here, I think we've got a new paradigm in our lives where we have a non-blinded trial that's not been published, and 100% of people, oh no, there we go, 88% of people would give a small dose with no granular data. So this is where we've arrived to in critical care, but I guess Kimia's point takes the day. So thank you very much, both of you, for participating in this. And thanks for the audience for listening in.
Even John won't vote for John.